Right, I think we can go ahead and get started. Welcome everyone to Geriatric Medicine Grand Rounds on November 1st. Can you believe it's November? Happens every year. I hope you all enjoyed your October 31st and aren't too full of candy to be able to enjoy this wonderful talk. But I'm glad you all joined us. We have great speakers today, and um, they came highly recommended by Dr. Vig, so thank you for that. But we have Reilly Masterson, who is a speech language pathologist over at our VA, and Nicole Askren, who's also a speech language pathologist at the VA, as well as the assistant chief for speech pathology and an ethics committee consultant. And I'm really appreciative that you've come to talk to us about communication and decision-making capacity in individuals living with aphasia. This comes up a lot for the folks that we care for in many settings. And I'm eager to learn a lot from you. So thanks for taking the time today.
Thanks for having us, Kate. So I'm Nicole, and I'm here with my colleague Reilly. And just a little background on our areas of practice. Reilly spends most of her time in inpatient rehab. A lot of times folks with pretty fresh strokes, new aphasia, exploring what they're able to communicate, what they need. And then I'm predominantly an outpatient. So I actually see a lot of the folks that Reilly started with, and then I see them when they're back to community dwellings. So it's an interesting continuum of care. And so we've sort of encountered lots of folks like this and look forward to sharing with you today. Can I advance this slide? Briefly, a lot of folks think of speech pathologists in the hospital setting as your swallowing folks. We certainly evaluate and treat oropharyngeal swallowing, but there are so many other aspects of our field that I hope people don't forget about, because we might be able to be very helpful, especially for situations like we're going to talk about today. So we certainly address cognition, speech, voice, fluency, and then language especially, which is what we'll focus on today. Next slide. We like to start by just providing a nice definition of aphasia. You'll see that this is cited from an article in 2022. So this continues to be a discussed topic, depending on the school of thought or the researchers that you're talking to. There are a variety of ways that this is defined. I really like this definition, which is aphasia is a communication disability due to an acquired impairment of language modalities, and I'll define that in just a second, that's caused by focal brain damage. Aphasia may affect participation and quality of life of the person with aphasia, as well as their family and friends. Aphasia masks competence and affects functioning across relationships, life roles, and activities, thereby influencing their social inclusion, social connectedness, access to information and services, equal rights, and well-being in family, community, and their culture. As speech pathologists, one of the things we'll do in somebody who has aphasia is try to really dig down onto how they perform in each of the 4 language modalities. So you'll hear us talk about that a lot. These include, and there's a figure on the right-hand side of this slide, auditory comprehension, which we colloquially refer to as listening. Verbal expression, so somebody's ability to produce spoken language. Reading comprehension, so what they can understand in written text. And then written expression, so anything they can express in a written format. And that these days includes texting and typing. Next slide. I just want to comment on a couple things that are important to keep in mind about aphasia. Speech pathologists, especially those who study a lot of aphasia specifically, are pretty specific to describe this as not a loss of language, but it's rather an access issue. So they haven't necessarily lost semantic information, for example. They haven't lost that this is the name of this is a pen. They just can't access it in the moment they might need it. Some features or behaviors that we observe in people with aphasia that help support this is that there are some cases where aphasia may be transient. For example, somebody who has a significant seizure and then presents with a post-ictal period where they are aphasic. Many times these folks improve and their language returns. People with aphasia, and I should have described this abbreviation that you see on the slide, PWA is how we abbreviate people living with aphasia. They are stimulable, meaning they often can improve or change to some degree when provided intervention. So a speech pathologist sometimes, or maybe somebody else that's not a speech pathologist, can improve their language comprehension or production with some type of technique. And then finally, people living with aphasia are variable. So sometimes they can recall the name of the pen, but sometimes they can't. They might want to call this pen this a pen right now, and they can't do it. But maybe 2 hours later, when they needed that pen least, they're able to recall that or retrieve that word. Next slide. Traditionally, aphasia syndromes or presentations were classified into, I'm sure many folks here have heard of the classifications of Broca's aphasia, Wernicke's aphasia, conduction aphasia. And what we've learned over time is that people rarely present specifically or exactly like those profiles. Up until actually this year, there was just an important article published exploring how we could better classify aphasias. But up until this year, and maybe in the last 20 years, we really have moved away from calling things Broca and Wernicke's because people just generally don't present exactly as we would hope when we read what a Broca's person looks like. So on the left-hand side, I really like this illustration by one of my former mentors and colleagues, Will Evans. He just on the left-hand side, these distinct colors sort of depict somebody like those different classifications, Broca's, Wernicke's, etc. But in reality, is what we see on the right is really much more of a mix of that, especially in our folks who may have had multiple strokes or have other concomitant comorbidities. Next slide. And then lastly, before we get into the meat of our talk today, I just want to mention that aphasia, sometimes we get referrals for folks that say this person is aphasic. And then when we meet them, they're actually not aphasic at all. And aphasia kind of comes with somewhat of a bias as to what we would expect somebody to understand of us or express. And they might actually be presenting with a motor speech disorder, dysarthria, or apraxia. I won't read the exact definitions out. They're on the slide for you. But just want to comment that aphasia is not a motor speech disorder. It is a language disorder. And sometimes we always are able to help tease that out, but sometimes that can be confused. Now, certainly people, especially if aphasia is due to stroke, can present, or these disorders can present in unison. So they can have aphasia and dysarthria at the same time. Next slide. I'll pass it on to Reilly.
Thanks, Nicole. I'll now transition to talking about the meat of our presentation today, which is going to be reviewing an article titled Communication Strategies to Support Decision-Making by Persons with Aphasia, a Scoping Review. And this article came out in June of 2023 from Stepanovich and colleagues. And I thought this was a really nice article that synthesized the information that we have out there about what type of communication strategies can be used to support decision-making in individuals living with aphasia. So the article aims to identify these 3 key points. And what I hope that you will take away from this presentation are different types of communication strategies that can be implemented during any decision-making conversations or evaluations for capacity for individuals living with aphasia, as well as increase awareness to the types of resources and tools available to you to complete these types of evaluations and discussions. So the article does a really nice job of providing some background information on what's already known about individuals living with aphasia. And this includes that people living with aphasia have the right to be given the opportunity to participate in personally relevant decision-making through all stages of life. And research has shown that decision-making can be enhanced with trained communication partners and if supports are provided that reduce the linguistic and cognitive demands of the task, as well as support the expressive abilities of the person with aphasia. And this idea is really the foundation for what's called the Supported Conversation for Adults with Aphasia, or SCA approach, which was developed by Kagan many, many years ago. And this really focuses on training caregivers, family members, healthcare professionals on how to implement use of communication tools and strategies to support not only the expression of individual with aphasia, but as well as the comprehension during these types of conversations and just reintegration into the community. Research has shown that every adult starts with the presumption of decisional capacity, which really embodies that fundamental principle of autonomy. We acknowledge that the presence of neurological pathology and any associated difficulties with language and/or cognition may impact an individual's capacity to make decisions. However, Kagan also identified that it could be impacting their ability to reveal this capacity to make decisions. Again, thinking back on aphasia is an access issue to language rather than a loss of language itself. So that difficulty with access is impacting their ability to convey their decision-making capacity. Nicole and I both work at the VA Puget Sound, and so here we have a pretty clear definition outlined of what decision-making capacity is. And again, we presume that all of our patients start with decision-making capacity, unless one of these three factors has come into place. And in which case that, if there's question of that, we tend to have either the medical doctor or the psychologist complete an evaluation to confirm or deny this. Brady and colleagues in 2012 outlined this concept of the continuum of capacity, which is referred to in the article that I'm reviewing today. And thinking about this as a spectrum, often in correlation with the severity of an aphasia diagnosis. So on one end of this continuum, you have individuals who have a rather mild language impairment. So a mild aphasia, maybe only some very specific deficits related to higher level functioning in auditory comprehension or with reading or writing. They only need a small amount of support and are able to make their decisions independently just by using these supports on their own. On the other end of the continuum, you have individuals who have a severe language that may be co-occurring with significant cognitive impairment as well as a result of their injury. And even with the use of strategies or techniques, the impairment is just so significant that they may require a proxy decision maker. However, they've identified that majority of individuals with aphasia will fall somewhere in the middle of this continuum or this spectrum. So these are the individuals who have retained the capacity to make informed decisions, but are not able to reveal this capacity because of their language impairment. So again, they, with the appropriate level of supports and tools and strategies, they do have the capacity to make these decisions, but that's rather challenging to convey to the individuals who are completing these evaluations because of their language access impairment. I won't spend too much time going into the details of this slide, but the article does make the distinction of the different types of decision-making in regards to supported decision-making and support with decision-making and shared decision-making. We anticipate this is a concept or several concepts that's familiar to you all, but it is something that we take into consideration when discussing, the recommended communication tools and strategies, and preparation for the types of evaluations and discussions that you may be having with patients. So the article summarized 16 articles that really reviewed the different types of communication strategies that appeared most beneficial when completing decision-making evaluations, and helped to identify the most commonly identified support individuals. So, who is participating in these discussions and supporting the individual with aphasia in preparation for this. They identified that out of all of these 16 articles, the most common decision that was being evaluated was whether or not the individual with aphasia had the capacity to make the decision regarding discharge planning or their living arrangements from the hospital followed by being able to provide informed consent for research studies. Majority of these articles actually provided a pretty detailed description of the process used for implementation of communication strategies to support individuals with aphasia. And this is what I'll spend the next several minutes talking about, and kind of, again, the bulk of what we hope will be conveyed in this presentation and be taken away for use in clinical practice. So the article breaks down the different types of communication strategies to support individuals with aphasia into 7 main categories, which are outlined here. So I'll spend some time going through each of these and providing some examples of each. Again, with the hope that these are some ideas of, things that can be implemented in clinical practice if you're encountering a situation where the, decision-making capacity of an individual with aphasia is being called into question. So the first category that they discuss are general strategies to support decision-making by the person with aphasia. And first and foremost, this starts with acknowledging the competence and the strengths for individuals with aphasia. So starting with that presumption that, again, this is a language access issue, we are presuming that they have capacity to make their own decisions, and this evaluation would be used to, again, either confirm or, call that integrator question. Acknowledging the strengths of the individual with aphasia is critical to supporting that, because a lot of individuals with aphasia will have relative strengths in regards to their language function. So it's not uncommon that we would see individuals who maybe have significant difficulty with verbally expressing themselves. However, their writing is relatively strong in compared to that. And so they're able to, express themselves in a written format to convey their wants and their needs and their goals. Sometimes we'll see, the opposite, where they're able to, verbally express themselves, or they can take in information verbally, but when provided, written material regarding the decision that they are being asked to make, they have significant comprehension breakdowns. So it's important to understand, exactly what the language profile of the individual with aphasia looks like, so that we're really catering to their strengths during these discussions and optimizing their ability to participate and make the decision if able to. They also acknowledge how critical it is to set aside sufficient time for the decision-making process. And this not only includes time for the actual evaluation or discussion itself, which in individuals with aphasia, it's not uncommon that this would take, several visits or several sessions to complete this in the entirety, but also acknowledging the amount of time that's required for preparation of materials, for the chart review, to really, again, get a good idea of what their language profile looks like, and for collaboration with any, interdisciplinary team members that are going to help support, that individual being able to participate in this discussion. So, again, making sure that it's not just that time for the decision-making conversation itself, but all of the things that come before that. Another generalized strategy for implementation is controlling the environmental stimuli in the situation or for that actual evaluation. Here at the VA, we unfortunately have a lot of 2- and 4-person rooms, and those are rather challenging environments to complete something that's, this high stakes. It's really important to be able to kind of create a distraction-free environment. So finding a quiet, private room to be able to complete these evaluations, ideally being able to have a table in front of the individual so that you can use, multimodal material to help support their understanding and their expression. Not having, interruptions from other, team members, or having, machinery or equipment from, nurses or the roommates going off. We really want to optimize the setting to be able to have this important conversation. They also recommend, identifying any important members or any important individuals to the patient that's being evaluated. If this is a family member, a significant other, they have somebody else who's identified as their, DPOA, who are the critical individuals in this person's life, and would it be appropriate to have them as part of this discussion and evaluation? And then the last general strategy that's discussed is making sure that any sensory aids that the patient uses is available to them. So if they have hearing aids, making sure those are in place and in working order. They're not, full of earwax. They're not, out of battery, that they're really being able to take in any verbal information that's being provided to them. As well as making sure that, if they wear glasses, those are available so that they have access to any written material or any picture material that you would be using. The next category of strategies that's discussed are strategies to convey verbal information. So these are strategies that you as a provider would be using when providing any verbal information to the patient about the decision being made. This starts with presenting information in more than one modality. So we do know that individuals with aphasia, many of them have difficulty with auditory comprehension. So verbal information that's provided to them can be challenging. And one of the ways we can reduce the barriers to that is by using more than one modality. So supporting whatever we are saying verbally with, again, written materials, picture materials, gestures. And then for that verbal material that's being presented, using a simple sentence structure and, semantics that's going to be well recognized by the individual that you're speaking with. So avoiding the use of medical jargon, the use of acronyms that they may not be familiar with, and using everyday language that's going to be more recognizable to them, and hopefully easier to access in their vocabulary. They also recommend using direct sentence structure, so being very active about how you are speaking to the individual rather than using any passive sentence structures, as well as repeating the information, stressing keywords when needed, and then pausing in between bits of pieces of information. So if you're giving them, a rather significant piece of information or asking them a rather important question, giving them that additional time to pause before you continue speaking so that they really have the time to process that information. Some strategies that can be used when you're conveying written information to the patient are similar to those used with verbal information. So again, using a simple syntactic structure, simple sentences that are active in nature, and avoid the use of medical jargon or acronyms. It's important to also consider using pictures or symbols that coordinate with the written information that's being provided to them. That can really assist with the comprehension of those written words. And the last strategy for any written information that's being provided, which you'll see in some tools that we'll review later, include using increased font size, as well as, bolding, underlining, or use of italics of any keywords or points that can really help kind of convey that main idea that's being addressed. Some strategies to ensure comprehension. So these are things that providers can do to help the individual being assessed comprehend the information that's been given to them. One of the big ones is asking yes/no questions to confirm understanding of either the question asked or the material being given. I will say a caveat to this is it's really critical to understand what the reliability of the yes/no responses are in individuals with aphasia. It's not uncommon for there to be a discrepancy between the reliability in yes/no questions provided verbally versus in written format. This is usually something that the speech pathologist will evaluate the reliability of auditory yes/no questions versus written yes/no questions, because we want to be using which of those is going to be more accurate. So if we know if patients having the written format of yes/no questions is going to have a more reliable answer, that would be how we would recommend confirming comprehension of the material being given. When giving these yes/no questions, it's also important to consider the observation of body language of the patient that you're evaluating. So oftentimes with individuals with aphasia, we can learn a lot about, how they're processing information through the body language and nonverbal cues that they're giving them. So if we're seeing any visible signs of frustration, we're seeing any facial expressions that may suggest confusion, it's kind of a sign to take a step back and pause, perhaps think about rephrasing or repeating the information that you provided to them, trying a different multimodal support, bringing in the pictures of the written material if not already used, and seeing if that helps, provide some clarification and perhaps changes their response. Again, you want to allow this frequent verification of understanding. So rather than waiting till the end of the evaluation or the discussion to see if the individual has comprehended the information that's been provided to them, taking those frequent pauses in the middle to allow for the opportunity to ask questions, or again, to be able to stop and recognize those nonverbal cues in the moment, rather than waiting till the end to address multiple things at once, which could be rather overwhelming for an individual who has difficulty with accessing the language that they are trying to use during this assessment. Some strategies to support the individual with aphasia in weighing information and reasoning about options includes presenting the most relevant information to the decision that's being made, and considering use of a visual, step-by-step process of the decision-making, process that's being completed, and providing hypothetical, simulations with the risks and benefits or potential outcomes and implications of each choice. Again, both in a verbal format as well as in a written format and with pictures if possible. Moving on to some strategies to support the expression of persons with aphasia, is allowing any, modality of a response to be accepted and providing a range of choices that the individual with aphasia can use to convey, their opinions and their thoughts about the decision being made. So recognizing that the individual with aphasia may be able to respond verbally and, convey their decision or their response through spoken language, but also recognizing that a response conveyed in, writing or by pointing to pictures or written material that's being provided is also, indicating the choice, and they're communicating still, even if it's not through a verbal means. Again, similar to some of the other strategies, observation of body language, again, is really critical here because they may be giving some signs non-verbally about how they're expressing or how they're feeling about the decision that's being made. And then the last category that they talk about are strategies to verify that the information conveyed by the person with aphasia regarding the decision has been understood. So making sure that you as a provider have interpreted the communication attempt from the person with aphasia that matches what they had intended to say. This often involves repeating what had been conveyed to you. Again, this could be verbally repeating this information, providing a written description of what they conveyed to you, or showing the picture materials that you maybe used, asking those yes/no questions to confirm whether or not this is correct. And if there's any uncertainty, expanding and summarizing that information with those written or picture materials as well, until you feel like you've got a good understanding of what had been conveyed by that individual. So these are the strategies from those 7 different categories that were cited most frequently throughout the 16 articles that were reviewed as the most critical or the most beneficial that were implemented in decision-making evaluations and conversations. So you heard me mention multiple times about using more than one modality. So being prepared to have lots of different materials to provide, and knowing what to tailor to that patient depending on what their language strengths and weaknesses may be. 11 of the articles cited the importance of acknowledging the person with aphasia's competence. Again, this is going to help promote that collaboration and allow that person with aphasia to be able to kind of initiate being able to participate in this discussion more, rather than feeling like they are, sort of out of control of the situation, which is something that's pretty common with our individuals with aphasia. And then again, simplified language, allowing that sufficient time for decision-making process. You've heard me mention, preparation of written materials, of pictures. Those are things that take time to do prior to even beginning this discussion or evaluation itself. Out of the 16 articles that were reviewed, the most frequently identified support individuals were first family members, but then followed by speech pathologists. So out of all healthcare professionals, individuals with aphasia benefited from having, collaboration with the speech pathologist with themselves as well as with the medical team who's completing the evaluation. Again, to really identify what their strengths and weaknesses are as part of their language profile, and being able to provide the recommended tools and communication strategies that can really empower that individual to participate in that discussion and evaluation to the best of their ability. So Kagan in 2020 clearly differentiates the difference between, supported decision making, which, is when it's shared amongst, individuals that are, selected by the person with aphasia, usually family members and, their medical team, versus the provision of communication support during that decision-making process. So we as speech pathologists recognize that we are not the providers that are completing these decision-making evaluations ourselves. However, we can play a really important role in being able to collaborate with the providers who are completing this evaluation to talk about the language profile of this individual, to talk about which communication tools and strategies might be most beneficial to implement during these really important conversations and decision-making evaluations. I wanted to spend the next few minutes reviewing some current tools that are available that you may or may not be familiar with that can help support the use of communication tools and strategies when it comes to decision-making conversations and evaluations. Briefly, there is a tool out there that's called the consent support tool, which is used for informed consent in research studies. I won't be reviewing this one today for the sake of time, but it is something that's available if that is pertinent to your practice. I'll spend the majority of the next couple minutes talking about the CASE, which is the Communication Aid to Capacity Evaluation. And this is a tool that's specifically tailored to individuals with aphasia. And is specifically related to discharge planning. And then I'll move to the MCAST, which is the Mental Capacity Assessment Support Tool. This is a more generalized tool or document, not specific to aphasia, that does have some questions to help get you thinking about, what communication impairments or barriers may be present. And this is a tool that can be used for a wide variety of decisions to be made, whether that's discharge planning, medical decision-making, financial decision-making, just a more general tool to be used. So I'm going to go ahead and stop sharing the screen and switch over to the CASE, which the CASE, again, is the document that is specific to individuals with aphasia and related to decision-making capacity. Nicole, will you just give me a confirmation that this case is showing up? Okay. So you can see here, perfect. So you can see here that it's got some of those strategies we've already talked about for multimodal communication. So you've got the simplified language with the bolded font, as well as a picture representation of what information is going to be conveyed to the individual. So this document came out of the Aphasia Institute, which is in Canada. And I wanted to briefly go through just the overview of how it works and really how simple it is to implement into clinical practice. So they go over some background information on how the tool was developed and have pretty detailed instructions for administration, both for you in a written format, but there's also a training DVD that can be completed that goes step by step, how to administer this to an individual prior to actually giving it to them. We've talked about the importance of doing a really in-depth chart review and consulting with pertinent team members, particularly the speech pathologist, when we are working with individuals with aphasia. And so they give this this nice outline of, things to be considering when completing a chart review, what type of communication impairment they have. Again, like Nicole mentioned, this is really important to be able to understand, what their strengths and weaknesses are and differentiating whether this is a true aphasia versus something like a motor speech impairment, which, may have been inaccurately documented at one point in time. It's important to recognize the most effective form of communication, again, consulting with a speech pathologist before, having an idea of, is written information or verbal information more accessible to this patient, because that's going to kind of guide which direction you're going to be completing this evaluation with. The other important thing that we see often with individuals with aphasia as a result of a stroke are not just visual impairments due to, age, but visual field deficits and neglect are pretty common as well. And so that's going to be important if you are using picture or written stimuli, being aware of any potential visual neglect that could impact their ability to access that multimodal information that's being provided to them. They go through, again, specific details about when to administer the evaluation and where. Those are those general strategies we reviewed about controlling the environment prior to beginning the evaluation. And then some steps for how to administer this. And so there is a evaluator's version of this tool that has very specific prompts for you to be able to provide some reminders about nonverbal cues to be looking for throughout the assessment, as well as recognizing that, the patient may respond in a variety of modalities throughout this assessment, and those should all be taken into consideration. I did want to point out that one of the items to remember that's listed is knowing whether or not the individual has a communication book or communication system. So as speech pathologists, in addition to treating the language disorder itself through restorative treatment, one of the things we do is we also initiate compensatory treatment methods. So this may include using a communication binder that has some printed pictures of, the family members related to the patient, of, their home environment, their most frequently requested items, or perhaps they may have a higher text system. These are examples of what's called alternative and augmentative communication, or AAC systems. So we might have individuals who have a tablet with communication software programmed into it that they use to select information that they're wishing to convey to individuals. These are really important things to be familiar with prior to that evaluation, because you want to make sure that you're interpreting how they're using the system appropriately. And sometimes they can be helpful tools for you as a provider as well to use with the patient to support their comprehension. There again is very specific scoring criteria for the case. This includes both verbal and nonverbal modalities to help you, complete your judgment of the individual's decision-making capacity. They go through some reminders of, again, those strategies that we discussed from those 7 categories. So being able to get the information in to support comprehension of this material, as well as help the individual get information out or be able to express themselves. So again, using these, italicized words to identify where pauses should be completed to allow additional time for processing, and which types of words would be helpful to stress in both the verbal and written format. In terms of the actual tool itself, I will go through just briefly some examples of how this is presented to the patient. So again, these are stimuli that you would be using for providing both the verbal format, so reading these statements out loud to the patient, allowing them to read it with the written material, and then also having picture representations of that material as well to support comprehension. There's an orientation section that you can use to get familiar with it before it goes into the actual evaluation itself, which examples of include, identifying who helps them at baseline. Are they able to understand the proposed care placement? What is the decision that they're making? Are they able to understand that? And then are they able to convey their opinion about it back to you? And then at the end, there's very specific scoring criteria that can be used. And if you're unsure about how to interpret the responses of the individual that you're working with, there are also yes, no, and don't know cards at the bottom right here. Again, to be able to ask for those confirmation questions to help you feel confident in the interpretation of their statements. So that is an example of the case, which again is more specific to discharge planning for individuals with aphasia. I'm going to switch quickly to the last tool that I will review with you all today, which is the MCAST. And again, this is a more general document that's not specific to aphasia or discharge planning, but certainly has communication impairments as a consideration when completing these evaluations. So this starts by just, using kind of a framework of what to follow when completing the preparation for these evaluations. So what is the decision that this person needs to make? Why are you evaluating this person's capacity to make this decision? What is the impairment that could be impacting their ability to participate or make these decisions? Is this temporary? And then this is the main kind of preparation page that can be used to consider communication impairments that could be impacting their decision. So, what is the relevant information that they need to make that decision? If there's any cultural or ethnic or religious factors that could be impacting it, any communication needs, and identifying what those needs are and how you plan to support them. Again, if you're not sure about these things, it prompts you to contact the speech pathologist. And then this also, addresses the potential for any cognitive needs, any mental health or emotional needs, and who to contact to help support those needs. It also reviews the same strategies that we discussed about controlling the environment and limiting, potential distractions and competing stimuli. So, knowing which time of day and what type of location may be most suitable for the evaluation, inviting any professionals who can support specific needs. So again, this could be kind of a pre-meeting or collaboration with, the speech pathologist or any other relevant team members. Or, perhaps if, language is a concern in terms of English being a second language, having an interpreter, or even the speech pathologist there if helpful. Again, ensuring the sensory aids are available and in use, and then coming up with a plan of how you're going to use everyday non-specialist language. So, having prepared materials ahead of time that are going to be accessible to the individual. And then this is just some kind of questions that are more pertinent to the actual decision-making evaluation itself, taking into consideration all of those factors above that you had identified. So that is the MCAST. I'm going to stop sharing, and then the last thing I'll discuss before we open it up to questions is I did prepare a couple case studies that I'd like to review. And the purpose of this is just to describe two different individuals who both had aphasia but had different presentations, and both demonstrated the ability to have capacity to make their decisions as deemed by the medical team. So I will go back to our slides quickly. Okay. Okay, so the first patient that I'll present is KF, and he was a 63-year-old male who actually had a previous medical history of a developmental delay. So at baseline, had some difficulty with reading and writing. However, no known impact on his verbal expression or auditory comprehension. And he was independently managing his IADLs and working at the time of his injury. He presented to the hospital in December of last year with a left frontal temporal lobe subacute infarct, which resulted in a severe mixed expressive and receptive aphasia, and really no significant physical impairments as a result of his stroke. So he was ambulatory with only some mild balance changes. He ended up transferring to the VA inpatient rehabilitation unit. And upon admission, his communication was largely characterized by automatic social greetings and utterances. So these are often statements that are relatively preserved in individuals with aphasia just due to the high frequency in which they were used prior to the injury. So for example, his that were preserved were phrases such as "How are you?" "Nice to meet you," and "Thank you." And in addition to those phrases, he had a small handful of single comprehensible words. So he was able to say his name, He commonly used the word knife to refer to many different items and things in his environment, not intentionally stating that word as in the belief that everything was considered a knife, but that was one of the presentations that he had, which is pretty common in aphasia. And then the word friend. But for the most part, his verbal output was considered fluent phonemic jargon. So he didn't have any evidence of any motor speech impairments that impacted the programming or planning of his verbal output. But most of what he said would be considered nonsensical to us. He did, however, have relatively strong auditory comprehension skills. So he was about 90% accurate for yes/no questions that were provided verbally. So he was understanding the information that was being given to him and could answer appropriately, either verbally or through a thumbs up or thumbs down in response to those questions. Unfortunately, writing was not functional as a means of expression for him. He was only able to write out his name and his birthday. And so we had to resort to other types of tools and strategies. And he mainly defaulted to the use of gestures to express himself in the early days. So pointing to things in the environment, acting out particular tasks. And that was how we communicated for the most part initially. We completed some comprehensive aphasia testing that included a cognitive screener developed for individuals with aphasia. And throughout the course of his admission, we recognized that his cognition was relatively intact. He had strong new learning and carryover of therapeutic tasks and demonstrated good recall of the communication systems we were introducing to him. In addition to initiating restorative language treatment on rehab, targeting his specific deficits in verbal naming, we also introduced low and high-tech alternative and augmentative communication systems, including the use of a Lingraphica touch talk device. So there's a picture of that device here. It's a computer-based or a tablet that uses a communication software program that he was able to go into different semantic folders to look for his desired target and then press for it to say out loud for him to communicate. By the time that he discharged from inpatient rehab, he returned to independent living. So he completed primarily speech and occupational therapy and worked to ensure that he could manage his medications, grocery shopping tasks, cooking, and the use of transportation systems, including the use of both the bus and the ferry system, which he relied on prior to his stroke. He did demonstrate some difficulty with math and was able to identify that he wanted his sister to assist with managing his finances after his stroke. But for the most part, with the combination of using his AAC device, some verbal speech, which did improve with therapy, as well as his aphasia ID card, which is a small wallet card that we will often introduce to individuals with aphasia that list their personally relevant compensatory strategies or supported communication strategies that they can show to individuals in the community to advocate for their needed support. With a combination of those things, he demonstrated the ability to make his own decisions. So the doctors determined that he was able to clearly indicate his desire to return home to independent living. He identified his sister as his DPOA for both medical and financial decisions, and he also was able to communicate the desire to retire from his job after his hospitalization as well. Today, he continues to travel using the ferry and the bus despite his ongoing aphasia, and he continues to come to the Seattle VA for outpatient speech services and is making progress to this day. So a very good success story of an individual with aphasia who has demonstrated capacity despite the significance of his language impairment. My last case study that I will present is an individual who's a 66-year-old male who had a prior medical history of 3 prior strokes, but without any residual deficits, and was admitted with a new left-sided stroke that had a resulting moderate expressive and mild receptive aphasia, again with motor speech function relatively intact, similar to the first patient. He did, however, have some changes in his cognition, particularly in his attention and problem solving, but demonstrated relatively strong memory and visual spatial skills. Unlike the first patient that was presented, this individual also had a significant hemiparesis as a result of his stroke, which will come into play a little bit in regards to his decision making. His aphasia was characterized by halting phrases, significant agrammaticism, and word finding difficulties in verbal speech. He was able to write single words and some short phrases comprehensibly, but was rather resistant to using this as a form of expression, and was also rather resistant to using any sort of AAC system to express himself as well. He strongly valued being able to verbally articulate what he wanted to say, not just in a telegraphic form, but in a grammatically complete form. His auditory comprehension was similarly relatively intact for yes no questions and following directions. And given his goals of wanting to work on verbal speech, we targeted sentence production as our primary intervention for him. This particular patient strongly valued his privacy and independence and largely didn't accept any sort of physical assistance from nursing or therapy for his self-care tasks, despite his fall risk and his significant hemiparesis. This resulted in a lot of frustration because of his communication breakdowns with staff about the recommended level of support and his desire to complete tasks independently. And he also demonstrated some frustration about the slowness in his progress, especially compared to his spontaneous recovery from his prior strokes. He indicated the desire to return home independently due to fear that the medical team would recommend that he pursue placement upon discharge or discharge to the care of his family, whom he had a lot of tenuous relationships with. And ultimately discharged home from the inpatient rehab unit prior to his set discharge date against our recommendations, but was deemed able to make this decision. He conveyed to the doctors that he understood the risks and safety concerns of going home independently at that point in time, and ultimately left and returned home despite those risks. So in summary, kind of big takeaways from the presentation include that aphasia is an impairment that results in interrupted access to language rather than the loss of language function. And the use of supportive communication strategies can greatly enhance an individual with aphasia's ability to participate in decision-making discussions. And lastly, there are several tools and resources available to support providers in implementation of supportive communication strategies during decision-making evaluations. So I will be sending the slides as well as the MCAST and the case out to Kyle to disseminate to your team and anybody who's interested in considering use for future clinical practice. And we have a few minutes left for questions if there are any.
Thank you so much, and I'm appreciative that you're going to share those follow-up resources for us. If anyone has questions, feel free to unmute, or if for some reason you're not able to, you can put the questions in the chat. We're getting a lot of thank yous. Everyone's very appreciative.
Feel free to reach out anytime if there's questions in the future.
All right, you answered everyone's questions with your presentation. It was really fantastic. So thank you so much for taking the time, and I appreciate you being willing to answer any questions that come up in the future and sharing your resources. But this was wonderful. And everyone, before you leave, please fill out the evaluation survey to share your thanks in a formal way that we can pass on to Nicole and Reilly.
Thanks for having us.
Yes, thank you.
All right, there's the evaluation link. We'll keep this open for just a minute so folks have a chance to click on there, and then have a great weekend, everyone, and thank you again.
Thank
Happy
you.
Friday.